first one, so we're right in the middle of it, and we care for a lot of COVID patients, and it's a big problem for us. And did you know what I'm talking about? This is my team. I'm working at a university hospital in the south of Germany. I'm working in a medical ICU, so no anesthesiologists here. We have 30 beds, high end. We can do everything, dialysis, ECMO, respiratory care, of course, on all the beds. And we have a staffing which I'm quite happy with 1 nurse for 2 beds and 1 attending doctor for 7 beds, 24/7 all the year. And when we talk about sedation, first of all, I want to state that I don't like sedation at all. I think we can if we can get around sedation in our patients, this would be beneficial for all of us and especially for the patient. This is a patient here, obviously before the corona pandemic. You see him without a face mask, but he's watching television with a nurse of us, and we try to talk people down when they get agitated, and we try not to sedate them if possible. But with coronavirus, we have this first phase of silent happy hypoxia. You probably also noticed people who are severely hypoxic, but not so much dyspnea, and we don't know exactly how to deal with them, and I will come back to this problem later. But even in patients with on mechanical ventilation with a tracheal tube, you don't need sedation all the time. This is an elderly lady on my ICU, and perhaps you can see that she's on mechanical ventilation. She has a gastric tube here, and she's drinking water next to the gastric tube, and she's awake, and we need not a lot of sedation with her. So if we can get around sedation, we try to do that. But of course, you have to have sedation on your ICU, and there's many cases when patients need actually sedation. And this has been nicely summarized in a publication in the New England Journal 2014, and you can see that pain is a giant problem on the ICU, and multiple things cause pain to the patient. That's of course elements of routine care, physical therapy, turning. We have the endotracheal tube, which can cause pain. We have a tissue injury. I mean, they have a reason why they are on our ICU, so this usually causes pain. We have a lot of vascular access sites, so puncturing, which cause pain. And also there is a very important affective component that people think when they feel pain, they get worse and perhaps die, and so they are very afraid of the pain. Also, there is a big problem of agitation, and of course this has to do with NICE and substance abuse before, sleep deprivation, also withdrawal of chronic therapies, anxiety, frustration, lack of homeostasis, thirst, hunger, dyspnea, and also ventilator dysynchronicity, which was nicely referred to by the previous speaker. And there is a big problem of delirium, which I will not cover so much, but which is also discussed in this meeting. So we have a lot of problems for the patient, which we have faced with sedation. And when we talk about sedation, we have very different substances here. This is the ones that I use on my ICU regular basis: propofol, medetomidine, and clonidine. We also use ketamine, liquid ecstasy, and some lorazepam and midazolam, and we use volatile agent isoflurane. And why do we have so many different agents? And just to remind us, you already know that, but to remind us that we have a lot of side effects of prolonged sedation. We have drug accommodation with midazolam. We have delirium, which can be caused by midazolam. We have intolerance and tachyphylaxis with dexmedetomidine. We have the propofol infusion syndrome with propofol. We have the problem of fatigue with propofol. We have QT prolongation. We have psychomimetic effects, ketamine and haloperidol. And we have also hyperalgesia and opioid dependence in the opioids. So all the anesthesias that we give in the vein have a lot of side problems, and volatile sedation might be a great thing to come over that. And this is only one of several meta-analyses that you can find on the web, here comparing volatile sedation to IV sedation. And the two endpoints that I brought here is time to awakening and time to extubation. And you can see that both in the different studies and also in the overall is well in favor of volatile sedation. Please notice that there are only a few patients included in this randomized trials of ICU patients. So when we started volatile sedation on the ICU, we were looking for these two things, time to awakening and time to extubation, and we hoped that we could help our patients there. And the first patients that we looked at, and this is just the outline of the study that we published, was that we were looking at CPR patients. And we cooled CPR patients, all of them, 23 degrees for 24 hours, targeted temperature management, and then we warmed them slowly, and then we stopped sedation, and we want to see how they are neurologically doing. And we thought these are the optimal candidates for volatile sedation, and we compared patients on propofol with patients on isoflurane, but we didn't see any difference between volatile sedation and the IV sedation in these patients. And this is regarding times, first time to spontaneous breathing, here propofol in red, and isoflurane in black, virtually identical the curves, and also time to extubation, with patients in red virtually similar to patients with isoflurane. And this is the first thing that I had to get used to when focusing on ICU patients. It's not so much the sedation that keeps them at sleep, but it's also the comorbidities, and it's the agitation, and it's the other problems that they have that require sedation. So it's not only volatile sedation and the time period that it stays in the system, the patients on the mechanical ventilation. But what we did see is that we used significantly less opioid in our patients. This is isoflurane in black and propofol white, and you can see as long as we used volatile sedation for the first 36 hours, we had very low isoflurane, sulfentanyl doses in the isoflurane group compared to the propofol. So if it's not working so good in the resuscitated patients, what about COVID-19 patients? And this is just an X-ray of a patient just now laying on my ICU, but I guess you know all these horrible images of COVID-19 patients. And there has been a nice narrative review published in intensive care medicine about volatile-based sedation in COVID-19 patients. And it discusses very nicely why you could use it and what the advantages can be. But unfortunately, they don't show data. And this is a problem, that we don't have data on COVID-19 patients on volatile sedation. So please feel free to contact me if you have patients on volatile sedation, and we can perhaps share the data and look if it helps COVID-19 or not. So the next few slides will be on my personal experience in my ICU, and I'm here supported by a great group of doctors that are very enthusiastic and into research and look all these things up. And I just want to mention Viviane Zotzberg and Corinna Lang, also Josefina Udi and Markus Jekyll, that have been working on the data. We'll look at COVID-19 patients on my ICU, and I'm a referral center for RDS and ECMO. You can see here, this is all the patients, 1 to 34 and much more, but this is the first 34 that we looked at. You can see in black days on mechanical ventilation, you can see in orange days on ECMO, and you can see in green days on non-invasive ventilation, that most of the patients have a long time on mechanical ventilations or ECMO, and only a few periods of non-invasive ventilation could be established in this patient, even though we try to keep them on non-invasive ventilation. And we do not intubate patients just because they have COVID-19, but we try to keep them as long as possible on non-invasive ventilation. And they are all not only much of the time on invasive ventilation, they are also on our ICU for quite a long time. This is data from our hospital comparing patients with influenza, severe RDS. Here you see patients on the ICU, and you see in blue the influenza patients, which decrease over time, and like half of the patients have been dismissed from our ICU at day 17. For COVID-19 patients, this curve is much less steep, and we have 50% dismissal like day 35. So twice as long are COVID-19 patients on our ICU compared to influenza patients, which are also patients with very severe RDS. So very severely sick patients, long time mechanical ventilation, and a long time on the ICU. And they are on the ICU and they need a lot of sedation. And probably you noticed that on the bedside, and this is a nice study that I found published from Johns Hopkins University. And they looked at the first 20 patients with COVID-19 and they accumulated oral morphine equivalent dose and oral midazolam equivalent dose for their patients. And you can see that they all have, for example, the opioid equivalent doses of 700 to well about 1,000 over the course of therapy. They have this very high sedation, basically beginning at day 1 and up to day 21 or 25 here, and they have very high doses. So these are patients requiring a lot of sedation, and these are patients which also have a lot of putative side effects of the long sedation that we would give them. And we cannot just say don't sedate them, because we have a big problem with the coronavirus patients, because they can inflict themselves patient-induced lung injury. And that they have initial lung injury, you can see on the X-rays very well. And they have very distinct patterns of obstipations on the X-rays. And this is caused by capillary leakage and lung edema. And lung edema, as you know, causes an impaired gas exchange, which then increases respiratory stress. And we have to learn that in RDS patients, respiratory stress is not only caused by the lack of oxygen diffundating to the blood. You can take ECMO patients with perfect blood gases, but still have a very high respiratory drive. So this is more than just the CO2 in the blood or the PO2. It's not high enough in the blood. And this increased respiratory stress can cause a patient-induced lung injury. And we know this Pendeloff is a big problem in these patients. Unfortunately, I don't have time during this talk to talk much about patient-induced lung injury, but I'm very happy of the recent talk here about dysynchronicity with the respirator, and that we have to synchronize the patients, and especially in patients which are partly controlled, mechanically controlled ventilation and partly breathe themselves. You can have additive effects, and you can have very high pressure differences in the lungs, which cause then patient injury. And this picture I showed you already, but I want to highlight that several things that we have in our patients occurring also trigger faster respiratory breathing and respiratory drive. Pain, agitation, also delirium, also cause a very high breathing frequency, and perhaps a frequency that is not adapted to the blood gases themselves and can cause patient-induced lung injury. So in these patients, we have to have sedation, and this is what we saw a lot. And also, we have to do more things with the patients than just putting them in the bed and resting them. We have to move them, we have to prone them. And this is, I think, the key therapeutic intervention that we can offer to COVID-19 patients, and this is proning. Here you see the landmark study from 2013, where you can see that in RDS patients, prone patients have a much lower death rate than those patients which were only kept supplied. You know, in this paper, they prone for like 5 days. We prone much longer in our patients. These are the first year 32 COVID patients, and you can see the number of proning cycles that we did. And yes, we do have some patients which only get 1 or 2 because they don't have a severe RDS and they recover fast, but most of them need a lot of proning cycles, and we have some patients prone for over 30 days, and in order to manage the lungs. And this needs a lot of sedation for them. Of course, we try to have them spontaneous breathing also while prone, but you cannot always keep them spontaneous breathing, and also extubations, self-extubations of patients in prone. position is a potential very severely emergency that you want to avoid, so you need sedation in them. And also it has been shown before, and I don't have time to go into detail, but the longer you prone the patient, the better it is for the outcome. So we try to prone for 16 to 18 hours. This is all the proning cycles within our COVID patients. And you see that we have a median of 16.7 hours, which leaves like 7 hours on supply. When you think that you have to sedate them a little bit more to avoid much coughing when you turn them, you have 1 hour of deeper sedation before proning and 1 after proning, and you have only 5 hours left for the patient to get awake. And when you have 30 days of proning, you need to get them awake. You need to see how they're moving. They need to move their arms to avoid critical ill polyneuropathy and myopathy. And this needs a sedation that is very fast in action and also very fast to get rid of once you want to have the patient awake. And it's not only that they move and that they cough a lot, but it's also to detect if they have intracerebral bleedings. And this is a case series in our ECMO patients with COVID with fatal intracranial bleeds, and you need to notice them early, because if you notice them at this stage, you cannot help the patient. So you need a sedation that is not so deep, and you need a sedation that you can rid of very fast. And this is why we established volatile sedation on our ICU. And we had a different system some years ago, and we switched to the MIRUS system over a year ago, and we are very happy with them. And it's not only me being happy, but it's also the nurses being happy. And I strongly believe that happy nurses are the MVP for ICU therapy. This is the picture of the staff that's worked overnight for New Year's Eve 2019 to 2020. They were very happy at that time because the coronavirus was very far away. But you need to keep your people happy, and you need to keep them close contact with the aims that you want to achieve for your patients, else it will not work. And our nurses actually switched or made us switch to the MIRUS device. It's very easy, it's very convenient, it doesn't beep very often, it's very easy to monitor. You can see here the fat that is actually just put in the machine, and the machine keeps it stable, so it's very easy to sedate the patients, and we are very happy with that. And basically we try any patient that is longer than 24 hours to be sedated, to put them on a volatile sedation. And we have now a MIRUS on 6 of our 14 beds on one ICU and 5 on the other ICU. And we try to get more monitors to have all the patients on volatile sedation once we need to keep them on mechanical ventilation for longer time. So, and this is also my my conclusion. When we talk about sedation, first we try not to. It's not cool to sedate the patients, but you have to if the patient demands for it. And we usually start with propofol plus fentanyl in perfusers. We try to keep doses low in the perfuser so that it's not so easily to give them a big bolus. And we try to start the MIRUS and propofol weaning in all the patients that are expected to be ventilated for more than 24 hours. And in case of sudden sedation, we have propofol at the bedside, which can be used for quick sedation. When we're not using the MIRUS is in ECMO patients or some ECMO patients, when you have VA ECMO and there is not a lot like generic cardiac output, you don't have a lot of circulation of blood through the lungs, and this means that the CO2 in the lungs is very fast depleted, and then you have a very low end expiratory CO2, and you cannot use the MIRUS here. And also when the titles in VV ECMO are very low, you cannot use volatile sedation. Also, when we're using cholesterol inhalation, we're not using the MIRUS because the filter gets stuck frequently, but this is basically the only patients who are not using it. First of all, stay healthy and keep your mouth here covered. and I'm very happy to be part of this meeting. And I'm happy to take your questions. And also down there, this is my email in case you want to contact me. And especially if you have all time sedated COVID patients, please contact me. Perhaps we can do some research together. Thank you very much.
Thank you, Doctor, for your presentation, and I hope we will be able to invite you in person in Morocco as soon as this pandemic will be over.
I would be very happy, yes.
I have some questions about the volatile inhalation, volatile sedation. Actually, lots of the people who are with us are anesthesiologists, so they know isoflurane, sevoflurane, and other volatile agents. But I think I can talk for myself and also for the others. We have basically no experience in the long-term use of these agents. Usually, we use them in the operating rooms. So every surgical procedure duration is a few hours. So we know how to use them for a few hours. But now with this technique, you're saying that you're using isoflurane for sedation for a few days or maybe weeks. So are there any major secondary effects due to the long-term use of these agents?
On the bedside, I don't notice any of them. At first, we were afraid malignant hypothermia, for example, that might be triggered, but I didn't see any malignant hypothermia in any of my patients, and we're using it a lot. And yes, we're using it a lot of days. And there have been safety concerns published in PubMed, but on the other hand, there are safety concerns with all the other IV agents also. And so no, clinically, I don't notice any side effects, at least with isoflurane that we are using over a long time.
So my second concern is about the environmental issues. I explained in the operating room, we have a system installed to evacuate the expiration gas outside the room, not to contaminate the people who work there. But in an ICU, there is no such a system. So where does the expired isoflurane go in this system?
You can use a filter for that. We also don't have a way to evacuate the gas with our machines that we are using, but you can use a filter and it's filtered out at the expiratory end.
So even if I use this system for many days, there is no accumulation of isoflurane in the room?
No, not in the room, not for the staff working there. There's no accumulation. Okay. And this is one of the advantages of the MIRUS system, that also filling the machine is very easy. We were using another system before, and you had to the isoflurane into perfuser syringes, and this always, you had some leakage there, but there's not such a problem with the MIRUS system. It's very nice.
And I have a last question. It's about the pharmacology of isoflurane in COVID-19 patients. The problem for me is that the site we are using to give the medication to the patient is the same organ which is basically ill. So aren't there any pharmacokinetic issues with using the lungs at the site of administration of the drug?
So obviously there's no big data on that yet, and unfortunately. So I can only tell you from my experience, and from my experience, there is no problem at all. It works quite nicely, and we get the patient sedated even though the lungs are severely ill, and this is not a problem. We also, like when we have a patient on VA ECMO and we have a very small perfusion of the lungs, also volatile sedation is working there, and this is counterintuitive because you think if there's not much perfusion in the lungs, how should the isoflurane that is diffused into the pulmonary blood get to the system? But it also works. So, and if it shouldn't work, you notice it very fast. So, because the patient gets awake. But we had no problem using bone heart sedation in COVID-19 patients.
Thank you very much.
So what do you think, in fact, of the future of this kind of sedation instead of the classical, traditional intravenous sedation protocols?
So I'm a big fan of volatile sedation. It does not accumulate, and we have a very small half-life time, and you can monitor it nicely, because you can just say which fats you want, and you can just put it in the machine. I think it's great, and for every patient that I have on longer sedation, we try the MIRUS early. So I think this is the future for a lot of ICU patients that are longer time sedated. Of course, not for those which are very small sedation or very short period of time, but for longer sedations, yes.
Thank you very much for convincing us for this technique. We will see with our partner MEDCAPTAIN to get our hands on it and try it in our ICUs. So I really thank you for your presentation, for answering the question, and I invite you to come in person to Morocco after all of this pandemic is over to help us use this technique.
I would be very happy. Thank you very much for having me.
Thank you very much for your time. Donc on va enchaîner, on va annuler la pause vu qu'on a énormément de retard. Donc on va démarrer immédiatement et je vous demanderai d'être courageux parce qu'il nous reste que cette session-là, c'est la session de l'après-midi qui est réservée exclusivement aux urgences et on va commencer sur les chapeaux de roue avec le thème qui est d'actualité aussi bien dans le Covid qu'aux urgences, c'est-à-dire les accidents thromboemboliques aux urgences qui vont nous être présentés par professeur Chouaib. Donc professeur Chouaib, la parole va être à vous dans quelques secondes. Et c'est parti. Merci beaucoup, professeur Chouaib.
Bonjour. Je suis très heureux d'être parmi vous aujourd'hui à ce deuxième congrès, donc e-congrès de la SMAAR, pour présenter les accidents thromboemboliques aux urgences. Malheureusement, pour présenter sur 10 minutes, donc le thème il est très vague. Je vais présenter plus la pathologie qui présente l'urgence extrême, c'est l'embolie pulmonaire surtout, et surtout les aspects thérapeutiques de l'embolie pulmonaire, qui est donc sujet d'actualité pour la prise en charge, et surtout il y a de nouvelles recommandations qui sont catégorie. L'embolie pulmonaire massive ou à haut risque avec présence des signes périphériques de choc ou d'hypotension artérielle, submassive